limited resources settings with the burden of chronic hepatitis. So I hope that with this presentation, the doctors will have different aspects on how to choose an appropriate liver fibrosis evaluation methods. So for the first slides, I would like to introduce a little about the chronic hepatitis situation in Vietnam. So Vietnam is located in the Asia-Pacific region, and unluckily, we are suffering from the high liver-related death proportion. And in our areas, we have the high proportion of hepatitis B, hepatitis C, alcohol liver disease, and during the recent years, we also are facing with the increasing prevalence of MAFLD. So in Vietnam, liver cirrhosis is in the top 10 causes of death. And among the malignancy, liver cancer is now ranking the first in the prevalence and in the mortality. So it will give you the picture of how the burden of chronic hepatitis in Vietnam looks like. According to the data of WHO, the seroprevalence of HBV in Vietnam is ranging from 8 to 19% depending on the population of the studies. And the seroprevalence of HCV is ranging from 1 to 3%. However, when we are heading to 2030, it is the elimination target of the whole world. According to the prediction of WHO, we will have the decreasing trend of HBV-related complications such as liver cirrhosis or SCC. And the situation is also very similar to HCV. According to the prediction of WHO, we will have a decreasing number of patients infected as well as the complicated cases. So how about the alcohol consumption and the liver disease relating? It is also very upset, but Vietnam ranks the 5th in consuming the alcohol, including beer, wine, etc. So that is why the alcoholic related disease, liver disease in Vietnam is also high in the region. And I would like to quote one very famous sentence from Dr. Hans Popper, a very famous hepatologist in the world. He said that anyone who can stop or delay the liver fibrosis would be able to cure most chronic liver disease. So the situation in Vietnam is very typical because we often diagnose the patient in the advanced stage. And I think the task of the hepatologist is how to detect, how to screen the patient in the earlier phases. And I think the liver fibrosis evaluation is one of the most important key role here. So whatever the etiologies of the liver disease, but we all understand that the natural history of the liver disease will change from the liver fibrosis to the liver cirrhosis. And for the liver cirrhosis, we have to face with many complications, while in the liver fibrosis, if we can detect soon and if we can prolong this situation, the patient will have a better outcome. As Professor Huang mentioned, liver fibrosis evaluation is available in many algorithms of AASLD, ESO, or Asia-Pacific algorithms in chronic liver hepatitis management. And what is the role of the liver fibrosis evaluation? It will help us to choose which patient is appropriate in the treatment. For example, we can see in HBV management, it is very important when knowing that the liver fibrosis situation, because not many patients coming with elevating liver enzymes. But if we saw that they have the advanced liver fibrosis, we all know that it is a chronic situation and the patients will need to be intervened. And it is also very important because it can prognose which patient will be suffer from the complications of portal hypertension or the HCC occurrence. The situation is also similar with the HCV and NAFLD management according to many guidelines like the Asia-Pacific guidelines or the APASO guidelines on the HCV or NAFLD. Both of these guidelines mention about using the techniques to evaluate the liver fibrosis, but they also, doctors also emphasize that the availability of these techniques and the local cost of the modality is important. So this is the updated guideline from EASL several months ago. And I really like this guideline in two algorithms. The first one, you can see that if you see the patient in our clinic, if you are a general doctor or GP, so if you see your patient at risk of chronic liver disease, and when you evaluate the risk factors such as the virus, the hepatitis virus, or the metabolic cofactors, or the alcohol consumption, and then if you find out that your patient has the risk factors of chronic liver disease, what should you do next? So if you are not a hepatologist, so you can be familiar with the 5-4 because it is a very easy to use score. It only uses age, liver enzymes, and platelets, and then you have the result of 5-4. And then if you are in a center with more technologies, you can indicate your patient with the imaging to evaluate the liver stiffness before refer to the specialist. And that is the first situation that most of the GP could deal in the normal practice. But if you are a hepatologist, you will have more chances to see the patients with the advanced chronic liver disease. So at that time, as I mentioned before, the liver stiffness measurement will be very pivotal in evaluating whether your patient need the treatment, whether your patient has the higher risk of the complications such as the portal hypertension. And maybe it is a really good indication, non-invasive indicator for you to think about in which kind of patient you should indicate the endoscopy. So how to choose an optimal method to assess the liver fibrosis? I think the indication will depend on the availability of your medical site. You will pay attention into the accuracy of the technologies. And one is very important point in the developing countries is also about the cost. So we are familiar with liver biopsy, and we also familiar with the biomarkers and the elastography technologies. So the liver biopsy is considered as the gold standard, and many guidelines also agree in this point. And you can perform percutaneous via the ultrasound, or you can do under the CT scan. However, we also have several issues to consider. The first one is that if you want to evaluate the accuracy of the liver fibrosis, we have to guarantee that the sample size is enough with at least 11 complete portal tracts in the sample. And we also have to face with the complications. All of the interventions, ultrasound interventions, we will be afraid of the hemorrhage or the injuries to other organs. How about the serum markers? I think all of us know that the serum markers, the advantage of serum markers is that they are safe. They are non-invasive. So I think the patients are easily assessed with the serum biomarkers. However, there are also some problems with the serum biomarkers. Some biomarkers are not really specific only for the liver, And sometimes it is very difficult to differentiate the intermediate stages of the fibrosis. And also not all the biomarkers have a acceptable cost. Some of the specific biomarkers have a high cost, which will be difficult to approach for the limited resources settings. And when we think about an ideal biomarkers, you could see that besides the accuracy, we also have to pay attention on the availability and on the cost effectiveness. So let's go back to one of the easiest and the most popular score, 5-4. So when you use 5-4, you only need the age, the liver enzymes, AST, ALT, and the platelet. And according to the literature review, the 5-4 could diagnose accurately the advanced fibrosis like F3, F4, when comparing to METAVIR score by biopsy, with the IOC is relatively good, 85%. And when comparing 5-4 with the Fibrotest, we see a high agreement, and that is why 5-4 is used as a simple and accurate and inexpensive method to assess the liver fibrosis. Another one which is also common for the hepatologists is the APRI. So the APRI shows also the acceptable accuracy when we assess the liver fibrosis. However, we have to pay attention that it seems better in the chronic hepatitis C and the NAFLD more than the chronic hepatitis B. And the APRI is also good with the significant liver fibrosis. So it will be a good score when we have to exclude the liver cirrhosis. So how about comparing FIB-4, APRI, and elastography? So according to one study in chronic hepatitis B, who underwent the liver fibrosis management by the elastography, it showed that the liver fibrosis index measured by the real-time ultrasound elastography was the most accurate one, with the highest AUC comparing to 5-4 and APRI. And according to a very interesting study on nearly 100 patients in the NAFLD, they design the algorithm how to combine the biomarker with the elastography, and they find out that if we combine the 5-4 and the TE, we can achieve 90% diagnostic accuracy for advanced fibrosis in NAFLD patients. So I would like to introduce one biomarker which is present in Vietnam for recent years. It is M2BP-GE. So this biomarker is interesting because I will explain a little later when coming back with Vietnam situation. But this protein is excreted from various cells, including hepatocytes. And it was found that related to the progression of the hepatic fibrosis. And according to the pilot studies, they show that this protein increased significantly along with the progression of the hepatic fibrosis stage. So coming to the elastography, so thankful to the presentation of Professor Huang, very informative, and we can study a lot. So there are so many overlapping slides which I can skip. But we all are familiar with transient elastography TE because they were the first introduced non-invasive tool to assess the liver stiffness in chronic hepatitis patients. And that is also why they are the most widely used in the world. And there is a relevant scale for all the different etiologies. We can use the different scale for HBV, HCV, for alcohol patients, for NAFLD patients. And in the TE, as Professor Huang also presented in the previous presentation, we are all familiar if you performing this technique that it will use a dedicated probe, and you will see that there will be 3 modes in the screen: M mode, A mode, and elastogram. And depending on which system are using, we will have the CAP, the control attenuation parameter, or the UAP, ultrasound attenuation parameters, and the results will be obtained immediately. And the ultrasound doctors will see whether the quality of the TE procedures is enough. So the advantage of TE is that it is the most widely used. It is the validated technique comparing to the liver biopsy. It is really user-friendly because the machine is not so big, and it could be performed at bedside with a rapid time. So it is good, and the quality is well-defined, and the high oral. And it also proves the prognostic value for the short or the long-term outcomes in our patients. However, there are several other issues we have to consider with TE because it is separated with ultrasound machines. So sometimes if we have some issues, we could not evaluate quite accurately why the quality of the procedure is not as we expected. And we cannot choose the ROI. So that is also one of the things that could have the effect on the quality of the procedures. And it will have the difficulties when we perform with obese patients or when the patients have ascites. And it also range with the different operators. It requires the experience also. And sometimes we can have the false positivity when patients have acute hepatitis, or when patients have cholestasis, or if they have the liver congestion. So how about Fibrotouch? So Fibrotouch was introduced, I think, since 2014. And Fibrotouch have several systems, but if you use the FT1000, one of the things that I feel most useful is that it integrates with the image-guided detection system. I really like the system integrated with ultrasound because we can find the appropriate ROI. And another advantage of this system is that we do not have to change the probe for children or for obese patients, and it uses a foot switch. So I think it could save the time for the operator, and the difference among the different observers is low. There are several studies to prove the efficacy of Fibrotouch. So as I mentioned, because FibroScan is the first system and most widely used, so most of the other non-invasive methods will be compared with FibroScan. So for this study, 435 patients received both liver biopsy, FibroScan, and Fibrotouch, and compared to each other. And we find out that here in this study, the success rate of Fibrotouch is very high, I think every case, while we still have here in the FibroScan branch, we also still have several cases with the failure because the patient have the high BMI, the patients have ascites. And when comparing to the biomarker scale score like APRI or 5-4, the Fibrotouch and FibroScan show the significant efficacy when evaluating about the significant fibrosis and the liver cirrhosis, but there is no difference between Fibrotouch and FibroScan. And when comparing about the time the operators taking, it seems that the Fibrotouch because the Fibrotouch have the lower disagreement among the operators, so it has a lower time numbers of invalid measurements. So that is why the time consuming to perform Fibrotouch is shorter than FibroScan. And it is also good, not only in the chronic hepatitis due to the viral etiologies, but also good in the case of NAFLD. And I would like to talk a bit about another technologies, which is called AFI. So comparing AFI to FibroScan or FibroTouch, I think one of the very good points that have been raised in the presentation of Professor Huang is that because AFI is integrated in the ultrasound system, so besides choosing an optimal ROI, it is also very good if the patient have a focal lesion like SCC in the liver or other focal lesion in the abdomen. You can also use AFI to evaluate. And AFI also have a higher applicability than FibroScan. It is also good if patients have ascites or if you deal with obese patient. However, AFI use a different measurement, which is have to transfer into the TE to be equivalent. And the quality criteria is not really well defined, especially with the different etiologies, and require further studies. So for the shear wave elastography, it is also good in the scope that it is integrated in the ultrasound machine, and it also have a good performance in applicability. However, it is also very similar with AFI that it needs more validation, especially in the different etiologies. MRE elastography is a hot topic in recent years. We all know that it has a very good applicability. However, I think the biggest problem with MRE is the cost effectiveness, and it also time consuming. But the advantage of MRE is that you, besides liver cirrhosis evaluation, you can evaluate the focal lesions very well, and you can also evaluate the level of iron or the fat in the liver. So coming back to the situation of Vietnam, we have, as I mentioned, that we have a high burden of chronic liver disease due to many different etiologies. But in fact, the patients are managed by different doctors from different specialties, hepatologists, gastroenterologists, infectious disease doctors, or GPs. So this is a good point in the case that many patients could approach the health quality service, but it also have a problem because there are different scopes in the management of the patients. So for the non-invasive liver fibrosis approach, it is very common in Vietnam till now, and I think it replaced the liver biopsy till now because the patients will be easily accept the non-invasive approach more than performing the liver biopsy. The serum biomarkers or the imaging approach are still are also available, but it depends on the medical science. It depends on the levels of the medical science. The patient is in the rural area or in the urban area. The patient is in the province hospital or in the city's hospital or in the national hospital. There will be more and more studies being conducted, especially for different populations, because we would like to see if there is any difference in the different technologies or in the different etiologies. So when performing the liver biopsies, even though that it is not quite common until now for liver fibrosis evaluation in Vietnam, but when we apply the new technologies, we still performing the liver biopsies to compare. And the most AE that we are dealing is the pain. The patient often complain of the pain after performing the liver biopsy. And according to the guidance from the guideline from the Ministry of Health in Vietnam for both hepatitis B and hepatitis C, all the guidelines mention about the role of the non-invasive technologies, including the TE, or using the scores like APRI or 5-4 when when evaluating the chronic hepatitis patients. And in Vietnam, I think from last year in medic centers, there are studies in M2-PBGE, and I think they are the first one who performed this study on this one in Vietnam. And I think it is very good way to approach because not all the patients can go to the medical science with the TE or with the with other elastography using imaging models. So if the patient could have the blood test which can evaluate the liver fibrosis accurately, it is also a very good way. And in Vietnam now, especially in the pandemic recent COVID pandemic waves, we all see the situation that many chronic hepatitis patients could not go to the hospital, especially the hospital with the liver stiffness imaging modalities. So the serum biomarkers still play an important role, especially in such cases that I presented. And these serum biomarkers have shown the very good correlation when comparing with APRI or with 5-4. How about the AFI? There is also a large study in Vietnam comparing AFI and TE. And in this study, the operators showed that the very good correlation between the AFI values and TE. And we also have different studies to compare the AFI in different etiologies such as chronic hepatitis by virus or NAFO. And there is one study comparing AFI and FibroScan, and in this study, they also found out a very good correlation between AFI and FibroScan. However, the number of patients failed with FibroScan seems more than AFI. And how about Fibrotic? So in our side, we have AFI, we have FibroScan, and we just applied Fibrotic from this year. And we also find a very good correlation between Fibrotic and APRI. How about MRE? MRE has been started in Vietnam in one center, in Medic Center. And they also found the efficacy of MRE not only in evaluating the liver fibrosis, but also in detecting the focal lesions. And I think this is one of the most interesting points when we think about the MRE. And this is my nearly last slide. So I summarize for you as the reference. You can see that in Vietnam, the availability of the serum biomarkers, APRI 5-4 is cheap, available, and it seems simple. However, we could see that the accuracy in the intermediate liver fibrosis stage is not really as we expected. M2B is promising. The cost, I think, is acceptable. However, we still need further data. For TE, FibroScan is available in many medical sites, and the cost is also acceptable, widely validated. But it has problem with the obese patients or when the patients have the ascites. Fibrotic have a similar cost with FibroScan, but it is less time consuming. It has a good point with the ultrasound guidance, and I really love that we don't have to change the probe for the patients with obese, and it has the lower failure rate. AFI is good also, but with the integration with the ultrasound, so we can choose the appropriate ROI and also evaluate the focal lesions. But the AFI is like FibroTouch is not as common as FibroScan in Vietnam. MRE, now we only have one center and the cost is very high. But it's good when we think about screening the tumors or when evaluating other metabolic problems, especially the steatosis, or when we want to evaluate the iron accumulation. However, I think MRE until now is mostly have the role in the studies, like more than in the clinical practice in the limited resources settings like in Vietnam. So I would like to summarize my presentation in several points. The liver stiffness measurement is essential in chronic hepatitis management. And we can see that non-invasive methods play more and more important roles. Vietnam is suffering from a burden of chronic hepatitis due to the high prevalence of virus, of alcohol consumption, and increasing of metabolic disorders. And in Vietnam or in other developing countries, we have to balance between the accuracy, the availability, and the cost to have the appropriate indications. Thank you for your attention.
Thank you, Dr. Dao. It's quite comprehensive and informative speech. Thank you for your speech. And let me introduce the final speaker tonight, and Professor Wang Kyung Zhang. And he is a professor and a senior consultant gastroenterologist